As I mentioned that there is the global significance of this project. The steps done for putting the common master form. The first thing is I have selected all the ADR report forms of 6 countries. That is United States, Canada, United Kingdom, India, Australia, Netherlands. Dividing all the questions into separate sections, then I analyzed all the common components that are present in the form. Then I created the form, incorporated the common form into the app, seen that almost 3% of the questions across all the regulated reporting forms are similar. So the remaining 30% vary. So by the required additionally specific questions, so whenever there is a drop-down menu in the application where the user just selects the country and along with this master form, the additionals will be added. The comparative data analysis. So we not provide the comparative data analysis of the reporting we are doing. So we have included 1 million ADR report data of Canada and FAERS, which is Federal Event Reporting some database. So the first thing we did is converted all the raw data to CSV format. Then we initially developed a common schema by considering all the common components present between the data sets of 2 countries. And then we start preparing the search queries in a local database. And then started adding the API endpoint to the app. And later we have created the necessary filters. And later, based on the query filters, whenever the user selects the particular query, we made that the application displays the results. Coming to the results, this web-based prototype has successfully demonstrated all the functionalities. All the components that are included in the app were user-friendly, easy to use. The main object to provide the consumers with necessary tools required to overcome the barriers that we mentioned earlier with the under-reporting, the main objective was achieved. So I would like to utilize my time and I would like to share my application. Yeah. So this is the application that I have developed. So first component, the drug reactions. This has 2 input. So whenever your inputs some generic drug name, when it hits the search, all the adverse reactions in the FAERS database will be displayed along the count. This only gives the confidence consumers and also information regarding the already reported drug reactions associated with this particular drug. This is one example. And the second component, the assessment form. A simple questionnaire. Whenever the user comes, it's a straightforward question. Did you experience the symptoms before started taking medication or experience the symptoms less often? So he will just input that data based on his experience and hits the submit. Then this page will give the score. And this is the reference standard scale compare. So here is a 0 score or 1 to 4 score. There is a less possibility of association between the adverse drug and the reaction. If the score falls between something like a 5 and 8, there is a relationship between the reaction and drug. So this not only gives the confidence consumers by screening the actual adverse drug reaction drug, but also it boosts the confidence in reporting in completing the report procedure. This is the reporting service. So we have just included drop-down menus, as I mentioned, in 6 countries. So at present, when we click on the specific country, for example, if you choose India, we get the normal master form. So for example, if it's United States, in addition to the master form, you see outcome reported information, the extra information will be displayed on the analysis component. So we have provided the filters not only to just a brand name, but also to choose the dates to perform the comparative analysis between the two countries. So the first is the patient can select some drug like classic. So I randomly gave in the days. So when he's the search, all data. This data is being called from local database by SQL, and this is the data from FAERS. So it displayed simultaneously. So to perform the comparative analysis, we have included this. Coming to the discussion, in order to address the consumer needs for feedback on previous report areas, we integrate a tool into our system that requires US FAES for information on ADRs based on the user drug. But in addition to that, there are some countries which do not recommend the direct patient reporting of the adverse drug reactions, and like Germany and Portugal do not provide this functionality for the general public to do that. So these are something that requires special attention. If I think like including countries, this would be the other factors that to consider. And the patient giving forms were collected. These are all the regulatory agencies of 6 countries. So US MedWatch form is responsible for is the adverse reaction reporting form of United States, and these are the vigilance system of Canada. PVP is pharmacovigilance program of India is responsible for drug safety and pharmacovigilance. So these are all the regulatory authorities of the 6 countries that we have included. Coming to the conclusion, this is the first step focused on solely on concept reporting of adverse drug reactions by including all the tools required to overcome the barriers. To reduce the barrier associated with the underreporting, we did this web-based system and based functionalities using trusted resources to encourage the consumer to self adverse drug reactions. Coming to limitations in the future work of the project, this web prototype system usually needs to be evaluated against the traditional AR reporting process that are currently used by the consumers. And the next in this project would be to autofill the regular reporting form. The common form we have developed. So our aim is to autofill by mapping the data components of the actual reporting forms. So whenever users just enter the data in the app, the application has to autofill itself. And when he clicks the submit, that has to be directly submitted to the respective regulatory authority. And our future week will expand the information sources to aggregate the ADI reports from multiple countries and enable direct reporting from our system. Thank you.
Thank you, Deepak, for the excellent presentation. Does anyone from the room have any questions?
This is Professor Gary. Deepak, where would this be situated? Who would actually own this in the different countries? Would it be the regulatory agency? Would you see this being a separate organization? And if it is, how would you see getting around the security issues on that?
Yes, so I think regulatory authorities would be the best person to adopt this kind of web-based tool because I think the electronic health record system I have considered to clinical forms is so the health. There is a scale for the healthcare professional to use, which is Norwegian causality assessment scale, and there is no electronic form of Norwegian causality assessment scale available in EHR. So I think using this tool, adoption of this tool by the regulatory authorities would actually serve the purpose of the project, and also the approach would be very good. I don't know if FDA or someone who comes and really likes the prototype and they make some correction, that would be a great thing for this.
Thank you.
Thank you, Professor.
So Deepak, I have another question. So in your analysis of the different consumer reporting requirements from different countries, how are they different? For example, which country is the most comprehensive and which country has the least amount of required information, and how do they compare? And what is a optimal what is the balance in terms of the amount of information and the burden for the patients?
Professor. So my inclusion criteria, I included 6 countries. So I have developed the master form by separating them into each section. So the easiest and the minimum amount of options is the Australian reporting form, followed by the Canada, and then the remaining countries. But the United States have 50 different questions in order to complete the regulatory reporting procedure. So that would be a great burden for the consumer in order to fill the easiest is being the Australian reporting form, which simply has the question. So it's mainly demographics data and the start date and end date of the reaction and who is going to submit and the address. That's it. That is my observation when analyzing these 6 regulatory reporting forms.
All right, thank you.
Thank you, Professor.
If there are no other questions, thank you so much, Deepak. And I think we appreciate the excellent work and the presentation. Thank you so much.
Good
Thank
job.
you so much, everyone. Thank you, Professor. Thank you all.
So let's have the next presentation. Maria, are you ready? Please share your screen and your camera if you're willing to. Thank you so much.
Okay, so what are you, on the slide that you're seeing right now, is it just the title page? Sorry, I don't know what you're seeing. If someone could answer that real quick.
Yeah, we can see the title screen. Thank you.
Okay, can you hear me clearly too?
Yes.
Yes.
So my project is focused on decoding the classification of complete medical records. Differences can make changes. So the introduction for this project is giving you a little bit of knowledge on the medical record, which is the primary storage place for data and information that pertains to the healthcare services given to the patient. It has 2 purposes. One is a primary purpose and another one is the secondary purpose. For the primary purpose, it focuses on just assisting with patient care delivery, patient care management, patient care support processes, financial and other administrative processes, patient self-management. And for the secondary purpose, it just assists with education, regulation, research, public health, homeland security, policy and making and support. So for the purpose of this project is to decode how each state classifies a medical record as complete. It will help uncover any discrepancies in categorizing a health record as complete. And it will also help identify the most important measures used to assess the records. A little background to this project is the integrity of medical records is classified from the security of accurate and complete medical records. The accuracy of complete health records is distinguished through information governance, patient identification, authorship, validation, amendments, record corrections, auditing for documentation validity, as referenced through the HEMA work group. And the classification of a medical record was as confidential compliant is critical to ensuring documentation integrity and completeness. Some of the criteria measures that really assist with defining a medical record as complete is if it's really efficient, the quality of it, the security of it, the connectivity of it, and its accessibility. The methods used to execute this project was I performed a literature review through PubMed. I used the HEMA body of knowledge. I used Bloomberg Law and Westlaw Edge. The HEMA body of knowledge helped me collect policies and regulations and standards that would help define more what a medical record was. And then through the literature review, it helped me find out what a complete record, how a complete record is compliant, the regulations that are applied, and the standards necessary. And it also helped me identify the criteria of the measures that Joint Commission really analyzes when defining a medical record as compliant. And then through the research engines of Bloomberg Law and Westlaw Edge, it just helped pull information on the maintenance of medical records and how what makes up a medical record, the continent that makes it up, and how each state classifies its medical records as complete. In the results sections, you can see that I have analyzed and pulled the continent that makes a medical record complete in the states, in the Midwestern states. So here you can see Illinois, and I'm not going to go off and read all of them because there's so much and they're just so unique to each other. And this is for the rest of the states. But from the analysis, it is quite evident that each state has their own unique way of classifying a medical record as complete. And the differences among the state heavily impact like the coverage of information pertaining to administration, maintenance, documentation, and regulation. The uniqueness of these classifications from each state very much rely on the state law, because it is up to the state to really differentiate what policies and procedures they will use within the hospital to really identify what a medical record, how a medical record is complete, classified as complete. So it just grants them a little bit of permission to just have a more more freedom of how they want to like really regulate their medical records. So for the conclusion of this project, the study shows that fewer similarities among the continents selected by each state classifies a medical record as complete. The classification uniqueness from each state presents a depth of information that quite extrusionates the exhibit of a quality continuum of care. The lack of uniformity and standardization will hinder its growth in technology advances such as health information exchange. To an extent, meaningful use can be triggering effects in the completeness of data. Still, it could present interoperability issues with the clinical decision supports from missing uniformity from the states. And then the future directions that I encourage or foresee is the data collection of this study can provide a substantial body of knowledge that can be used as an exceptional framework for regulating medical records. This project has presented enriching information that will support documentation requirements, but has also introduced the need for standardization and uniformity among the Midwest states when classifying the medical record as complete. And then I would highly encourage for a more extensive picture, if a more extensive picture would like to be seen, then maybe the accuracy and integrity of medical records. And if the accuracy and integrity of medical records is questioned, then pulling an audit report from select healthcare facilities from the Midwest states would give them that bigger picture and a bigger comparison. Thank you. Any questions?
Thank you, Maria, for your excellent presentation. I have a question based on your research. What do you think are essential things that are missing in most of the states?
Based on what continent do you think is more?
Yeah, or what things for the integrity and the accuracy of an electronic health record, which things are good in one state and not so good in the other state, and what would you like to see implemented across states, not only the Midwest, but maybe the whole United States worldwide, in order to have accurate health records, because it benefits all of us?
Yeah, well, there's like a lack of a lack of like states using progress notes. So I feel like that's very important. So I would encourage them. I just feel like there needs to be a more standardization, like a more general way of completing a record that can be used by the states, instead of like the states having like the option of creating their own policies and procedures, just so like it helps with health information exchange and stuff like that. There's just so many, there's just so much continent that a medical record does necessarily require, that it's really hard to really tell you like, oh, I wanted to have this, this, and this, because at the end of the day, it's really what is really going to help with the care of the patient. I'm not sure if that really answers your question.
No, it does. It does. Somebody else?
Yeah, so I had a question on particularly if you say took Indiana, what is the completion criteria for Indiana? Like, could you list
For
something sort of it?
Indiana, yes. So for Indiana, there's like a specific, so there's just the continent that makes the record, and then there's also other criteria that I wasn't able to place on the slide because it's a lot of information, but the basis for it is like the documentation must be completed within 24 hours, and it must identify like the patient, it must have the medical history completed, and all these entries that I'm telling you, the physician or healthcare provider who provided the care must authenticate the entries. So other important documents that must be in the record is any like allergies or abnormal drug reactions, like the informed consents, laboratory reports, X-ray consultations, discharge summary, chief complaint, entries related to anesthesia administration, the progress note, the final progress note, dictated reports with findings or tissue removal, discharge diagnosis, authentication of I already said authentication of entries, time of dismissal, and disposition of patient. So like the discharge summary.
Okay. Yeah, that's a lot of detail, like lot of things.
It's a lot. It is a lot, but I mean, this information is necessary, right? Mm-hmm. And it's important when communicating from provider to provider.
Mm-hmm. So we also have a question from Dr. Fulton on the chat. What do you think will have to happen in order for there to be uniform definition of a complete medical record for the US?
I feel like there needs to be an agreement, a law set in place that requires that there must be uniformity, because if the law states that there is freedom for each state to really select the policies and procedures that work best for them, or what they want to see and stuff like that, what they want to implement within their facility, it gives them that freedom. So if it's not specifically like required by federal law or state law, or I would say federal law, in order to really see that uniformity, it has to be like implemented as a law, just so like the states are obligated to follow it, if that makes sense.
Mm-hmm. Are there any other questions?
No, thank you.
Thank you.
Thank you. Thanks for the excellent presentation. Let's have the third person. I think we have switched Saranya with Virendra. Saranya, are you ready? Could you please share your screen?
Can you see my screen and hear me as well?
Yes, we can see it and can hear you. Thank you.
Thank you. Yeah. Hello, everyone present here. I'm Saranya, and the capstone project of mine is satisfaction or potential of the telemedicine services amongst the healthcare providers. So, like coming to the objective of my project, so there were 4 main objectives, which is what is the potential of telemedicine, what are the various benefits and the barriers used in telemedicine technology, in using the telemedicine technology, what should be improved to increase the adoption of telemedicine, and what is the likeliness that the majority of providers will be using the telemedicine services after the end of pandemic as well. So the scope of my project revolves mainly around 2 dimensions, that is, increase the extent of healthcare services and also reduce the cost of care. Coming to the introduction part, so digital health is an effective combination of science and technology with healthcare, living, and society. So, like what is telemedicine? Telemedicine is the perfect blend of technology in healthcare through which, like medical services could be rendered to distant places without the actual need of the physical presence of medical practitioner. And it's also interesting to know that there has been many vast advancements in this sector and has spread to various specialties. So, there is telecardiology, telepsychiatry, telepathology, teleradiology, and even teledentistry as well, which is new, but yeah, it is growing. So coming to the background part, we all know that COVID-19 pandemic has pushed everyone into a complete new scenario. There is no physical contact and there are stay-at-home orders, but there is still a need for everyone of us to deliver the best healthcare services among all the chaos. Continuous monitoring of COVID-19 patients is required for temperature change and to monitor any development of severe consequences. And I think telemedicine can offer an excellent platform to continue the communication and the care. And also, telemedicine has proved to be very useful in terms of visual and audio communication, in terms of consultation, screenings, and follow-ups. And also, there are, some variables which have been recognized, which can be evaluated to, to understand the acceptance of telemedicine, and among these, perceived usefulness, which is the, how the provider feels about the advantages of the telemedicine, is one of the important variables. And telemedicine also provides an acceptable care delivery model and also allows to get an accurate health history, which in the long term helps in regulation of satisfactory treatment plan. And also, many specialties have been starting to integrate telemedicine in their practice, ranging from cardiac, surgery, gastroenterology, and also recently allergy and immunology specialties have been using it in vast purposes. And also, one of the major concerns which the providers felt that which caused reluctance in the use is the lack of reimbursement, because before the advent of COVID, there have been many restrictions in the reimbursement, ranging from geographic restrictions, payment parities, and coverage policies. So the methodology of my project mainly revolved around literature review and the existing survey data. And the survey data was, further organized and summarized in Excel with the help of with the help of pivot tables, and it was further converted into an interactive dashboard for to make it visually appealing and more understandable. So I involved 2 surveys in my project. One is the research and development survey, which was conducted by the National Health Statistics, and the other is the Telehealth Impact Physician Survey. So the first chart talks about how there is a sudden spike in the use of telemedicine in the last 1 year. Obviously, it's due to the COVID pandemic. And the second chart is from the Telehealth Impact Physician Survey. It says that it portrays how there are different challenges which an organization feels to maintain telehealth after the end of pandemic. So we can work on them to reduce those to increase the adoption. And it can be seen that low or no reimbursement and the technological challenges for patients have been perceived most by the organization. And moving forward, there were also some of the key charts again from the same survey. So the first chart portrays the different type of telehealth access used in the 4 regions of the US territory, and it can be seen that Zoom, telephone, and the Doxy mode of access was the most used. Doxy is also a type of platform where we can conduct video calls and services like that. And the second chart portrays how the remote sensor technologies and how many technologies were used across the United States. And it was seen that the majorly used remote sensor technologies were smartphone camera photos, audios, blood pressure cuffs, and body weight scale. So moving forward, some of the key insights were deducted from the analysis, and it was seen that there's tremendous increase in the use of telemedicine in the past year. And there are many predictive variables which can be assessed to understand the level of satisfaction. So some of the variables include perceived ease of use, attitude of the physician towards the use of telemedicine, and what is his or her behavioral intention of using it, and how he or she sees it as a benefit to the patient. And also surgery, psychiatry, pediatrics, and gynecology have been using predominantly across the four regions. And the most used type of interactions were the live interactive for home patients, live interactive for outpatient clinics, and the telephone audio. Telephone audio has been used predominantly across all the regions. And there are also many changes to the payment methods. So the most used were Medicare, Medicaid, and the private commercial payers, which include Aetna and the United Healthcare and all that. So moving forward, some of the barriers which were concluded that the topmost barriers were lack of reimbursement and payment issues, and the patients unable to use technology due to lack of literacy of the technology. So if one can work on them and attempt to reduce them, I think we can majorly increase the adoption and implementation. Also, some of the barriers were patients with speaking and hearing problems were unable to use. There was gap in patient-clinician relation. There is poor broadband internet, and there is lack of resources or proper equipments. There is privacy and confidentiality issues. So also one of the important concept which can be seen is the telemedicine billing. So March 2020 can be considered as the onset of COVID-19 pandemic, and all the certain changes to the billing happened at that time. So before that, there was a lot of regularity variability. There were different policies across all the states in the US. It created a lot of confusion and caused inequality in care. So also very few services were provided, which caused reluctance of the providers to use the technology. But after the advent of COVID, the government relaxed the regulations, and the policymakers they just relaxed it a bit, and there was increased payment equality, and also many services were covered, including new patient visits and all that. And even the private commercial payers, like the big ones like the United Healthcare and the Medicaid and everyone, they increased their and the Blue Cross Blue Shield, they increased their coverage to enhance the care. So coming to the discussion part, it can be categorized into like three essential domains. Like the COVID-19 proved to be a turning point for the implementation of telemedicine services, and in middle of all this situation, telemedicine proved to be an asset in maintaining care continuity. Although we have to continuously keep on evaluating the technology to understand the gap present between them. So I think the four main evaluation measures are demographics, care settings, motivation, and experiences of the providers. And also some of the strategies can be implemented, like harmonize the reimbursement criteria, and also increase the availability of resources, because everyone doesn't have equal resources, which creates a sense of digital divide between the patients. User-friendly platforms to improve access of care between patients and the providers. Education and training, policymakers should expand the access of broadband and technology as well. So thus it can be concluded that there is certainly increased use of telemedicine services due to relaxation of payment options and the onset of pandemic, it can be certainly said that there can be slight increase in the use of telemedicine, but it would be too early to accurately say that the future of telemedicine includes higher usage like the current scenario. Of course, some effective strategies can highly encourage the providers to adopt telemedicine and provide care. And one of the major limitation was lack of enough data fit for predictive analysis. And the future work of my project involves extensive research, development, and critical decisions, which would effectively remove the challenges and encourage more people to use these services. These are the references. Thank you for listening. Any questions?
May I ask you a question, Saranya?
Yes, Professor.
Saranya, when we started this project, you wanted to look at the cost of telehealth and to see if the healthcare could save by using telehealth. Why could we not do that project? What was missing?
Professor, there was a lot of inequalities in that aspect, and also there was proper data available in the literature that accurately talks about the cost-effective ratio among the providers, and also their thoughts and what are the perceptions. So yeah, that cost. That caused us to not include that, because when we don't have proper evidence to show, then it would be inappropriate to state anything.
So what did you learn the most from this project? What is the future, in 2 words, from telehealth? Is telehealth for everybody, yes or no?
I can't, I can't say yes also, Professor, at the, accurately, because, we have to keep in mind that every person is not, does not have the equal, the required resources and the technology required for the use of the services. So yeah, that's why I included the word digital divide, which has created, some has more resources and some has less. So, so yeah, if the government makes some significant changes that some at least some required resources can be provided to every set of population, then I think yeah, it can be increased in the future.
Thank you.
Thank you, Professor.
Are there other questions for Sharanya? Okay, thank you for the excellent presentation, Sharanya. And we'll have the next person come in. Amruta, are you there?
Can you hear me, Professor?
It's breaking up and very, very quiet.
And very faint, yes.
Mm-hmm. Yeah.
Can you hear me, Professor?
Not really clearly. I think you're still very far from the mic.
Can you hear me now, Professor?
Yeah, this is much better. Yeah, please share your screen and you may begin the presentation.
Are you able to see my screen, Professor?
Yes, we can.
Good afternoon, everyone. My capstone presentation is feasibility of differentiating physical activities in Parkinson's disease patients using biosensors. I'm doing this project under the guidance of Dr. Jones and J.J. Spiegel. Introduction. So I'm going to explain about Parkinson's disease. It is the second most common long-term degenerative neurodisorder of central nervous system. due to effect of dopaminergic neurons in substantia nigra of brain. 4% of people greater than 50 years were diagnosed with Parkinson's disease. Rise of incidence is seen globally from 0.1 to 0.2%. 10 million people were affected with PD worldwide. PD is more prevalent in men than women with a ratio of 1.5 to 1. The UPDRS scale is the gold standard for assessing PD symptoms. It helps in self-assessment and self-evaluation of symptoms that can help physicians monitoring the severity of symptoms. Parkinson's disease have two types of symptoms, motor symptoms and non-motor symptoms, which are included like bradykinesia, vocal symptoms, rigidity, postural instability, tremors, walking or gait difficulties, dystonia, and non-motor skill symptoms include mental issues, behavioral issues, sense of smell, sweating, melanoma, gastrointestinal issues, and pain. Coming to the background, physical activity plays a crucial role in Parkinson's disease patients, improving both motor and non-motor symptoms, evident with some studies. The benefits of physical activities are extensive, but the research was still going on. And based on physical activities, it can help reduce oxidative stress, enhances energy production, increases mitochondrial activity that can improve neuroplasticity in the brain. This study will help identify and understand the accuracy, intensity of specific physical activities that can improve symptomatic progression with the help of wearable biosensors in long term. It shows some evidence that physical activity helps minimize severity of symptoms by providing less harm to the patients besides improving motor and non-motor symptoms. The main objective of the study, the main primary goal is to develop a machine learning algorithm that can differentiate different physical activities in each patient using sensors. This study also helps to determine the frequency, intensity, and duration of time needed for each physical activity that could work best. The study's long-term goal is to evaluate the impact of intensive physical activities on PD symptomatic progression. Methodology. Approved by institutional review boards of Indiana University, Purdue University, Indianapolis, performed with the help of Rocksteady Boxing, Indianapolis. The time taken for the IRB approval is 4 months. The study device used was Biostamp RC10 sensor. Collection period is February 2021, and the study location is Rocksteady Boxing, Indianapolis. 8 subjects were recruited based on eligibility criteria, which includes inclusion and exclusion criteria. Data collection process. The research term will explain the study procedure, and then consent forms are taken from the participants before starting the study. The sensors are placed on 3 locations of their body with safety and precautions, which is on right arm, right leg, and left side of the chest. The exercises were video recorded and the timings are noted manually and counter-checked during data analysis. Starting and ending time of each physical activity is recorded. Results. Data analysis to distinguish each physical activity in each subject. First of all, the data is cleaned and separated based on each physical activity, and then all the physical activities are combined together. It helps in machine learning algorithms helps in differentiating each physical activity in each patient with an accuracy of more accuracy in KNN, which is 86%, and for random forest it is like 47.8, which is less accuracy in individualizing, in distinguishing each physical activity in each patient. Coming to distinguishing different stages in Parkinson's disease based on stages. It has followed the same process as each physical activity differentiation. We have combined all the data from each subject, updated with a new column of its stage number, trained and tested with supervised machine learning classifiers, and performed the results. And here are the results. KNN seems to be more accurate for differentiating each physical activity based on stages, with more precision, more recall, and more F1 score. And for random forest, it is less compared to other models. Data analysis to distinguish different stages of Parkinson's disease patients based on lower body movements, upper body movements, and whole body movements. As mentioned earlier, it is also performed with the same process. And for the results, it is based on the lower body movements. And KNN seems to be the higher accurate, logistic regression seems to be the lesser accurate, and decision tree seems to be a little bit overfitting. And based on upper body movements, KNN is more accurate in differentiating different physical activities and stages based on movements. And random forest seems to be lesser when compared to the other models. And for whole body movements, KNN performs best with accuracy of 99.7% and random forest is less with 82.4% accuracy and less precision recall and F1 scores. Discussion and conclusion. There are some studies that are evidence showing KNN as best classifier with 96% of accuracy as a diagnostic model to detect PD. Whereas another study shows that NNC algorithm is to discriminate different individuals from healthy individuals. And another study is also evidence showing KNN as the best algorithm to diagnose PD and SVM as best classifier by Shetty et al. 2016 to detect Parkinson's disease with good accuracy. In this project, KNN and decision trees are the best classifiers to distinguish different physical activities in each patient by interpreting the results. Along with that, they also played a major role in distinguishing early stages of Parkinson's disease versus later stages based on movements. Challenges and limitations. Challenges include due to COVID, IRB process took long time along with the data collection was postponed to because of online sessions. Reliability of sensors is inadequate due to fluctuations in the background signals. Each patient performed different physical activities every day. At first, it is difficult to categorize them, but their activities were classified based on movements at the end. Limitations include limited sample size, less resources, time constraints. References. Thank you.
Thank you so much for the excellent presentation. Does anyone have any questions?
I'm Ruta.
Yes, Dr.
So, first of all, thank you for the presentation and also for the collection and the analysis of the data. So, but what do the data tell you? Is it really possible to pursue or go to use the sensors to find out exactly what activity a patient is doing?
Yes, Professor. By using machine learning algorithms like the classifiers, we can differentiate a particular exercise or physical activity performed by a patient based on, I have performed that, I'll show you 1 second. This is the evidence saying that each physical activity can be separated from a data set which consists of like n number of physical activities.
And so, Amruta, which location is the best to finally, or the best to recognize the activity?
I think the chest, leg and arm makes more reliable because when moving their hands and legs, hand and leg sensor might work good for collecting the data. And in order to know the heart rate, or we can use chest sensor so that it can collect the data in the electrode.
So do you have data to show the difference between hand and leg and chest that compared?
Yes, Professor, I can show you. Just a second.
I just explained to us, that would be enough.
Each leg has accelerometer values and gyroscope values, and for hand it is same like leg, and for chest it is going to be like accelerometer values and electrode values. So the chest data will be quite different when compared to the leg and hand.
Thank you.
Thank you, Professor.
Amrita, I had a question on the modeling part, and I am a little surprised to see KNN perform this well. But did you have to do any kind of pre-processing before you trained the classifiers? And second, what K did you specify when you were doing the KNN?
So before doing the classification, I have pre-processed, like the combined all the data from each patient and then label encoded with activity label. And then I took K value as 2, Professor, for running KNN. it works best for this data set.
And how did you come up with that K?
So I have tried 3 different values, and then when I see the accuracy between 3 of them, I find K2 works best for this data set.
But I thought your class had like how many, 12, 15 activities? How many did you classify?
Actually, first of all, I have differentiated physical activities for each patient separately, and then based on the movements like upper body movements, lower body movements in each patient, I have combined all the lower body movements from each patient and then run the models. So I have done like the lower body movements separately, upper body movements separately, and then whole body movements separately by combining all the data from each patient.
Also, the final, there are 3 classes, upper body, lower body, and overall.
Yes.
And that's what you're trying to predict, not the exact specific activity.
No, professor. Like based on the upper body, lower body, and whole body movements. As each patient perform different activities, it is hard to do that. So we have separated that data like lower, upper, and whole body movements.
Okay. Okay. Yeah. Then I understand why to work for it. Okay. Thank you.
Thank you, Professor.
Any other questions, anyone? Okay. If not, let's thank you so much for the excellent presentation and move to the next one. And the next presentation is from Lavanya. Lavanya, are you there?
Yes, sir. Yes, Professor.
Yeah, please share your screen and start the presentation.
So can you see my screen and hear me?
Yes, we can. Thanks.
Thank you. So, one second, Professor, did I on my media? So my presentation, good evening, good afternoon, everybody. So my capstone presentation is on development of ontology knowledge model on first-time pregnant women. So my advisors are Dr. Jones and Dr. Kanita. Introduction. So ontology is defined as a knowledge model that consists of a set of concepts within a domain and relationships among them. In simple words, in the information sciences, ontology consists of instances or individuals, concepts or classes, attributes, and relationships between them. So I use the domain first-time pregnancy in my ontology knowledge model because first-time pregnant women are likely to lack skills and knowledge-related knowledge issues to knowledge-related problems to their bodily changes. So this may generate a feeling of unpreparedness to their new roles and responsibilities. So that's why I used this first-time pregnancy as my domain. And pregnant women need to develop awareness, which helps to improve the outcomes of their pregnancy. Objective and significance. So most women get anxious about the signs and symptoms they're experienced during their pregnancy since it's their first time. So they also worry about the fetus that is growing inside their womb. However, this study provides information related to signs and symptoms, fetal development timeline based on gestational age and significance of this study. So by the end of the construction, it is possible to implement the knowledge model. Furthermore, this knowledge model can be shareable and reusable with the technology independence. And so from here, the ontology development cycle starts. And the first step in that is scope and purpose of the ontology. The scope for my ontology was limited to healthy first-time pregnancy with the following main classes: symptoms, gestational age, fetal development timeline. Based on, for this ontology, I used top-down approach. So what is top-down approach? Top-down approach uses top-level or foundation ontology framework. It is a non-domain specific and consists of general or common terms such as object, property, relations across them. And this structure offers semantic interoperability, that is the ability of computer systems to exchange data with unambiguous shared meaning. And the purpose of ontology is to provide a knowledge model to first-time pregnant women and help to predicate the risk level in patients. So the second step would be the terminology. So different terminologies are used in this ontology knowledge model. For instance, women, pregnant women, fetus, gestational age, signs and symptoms, findings, and it is subdivided into normal and abnormal action plan. So this list of terms further classified into cluster of concepts, which the study further describes into formal and informal. So in the informal definitions, I provided a few of examples, what I used. Pregnant woman is a woman that has a health condition called pregnancy. And pregnancy is a health condition that has a fetus developed inside a pregnant woman. And gestational age is a health measurement or health assessment that calculates the age of pregnancy. So when coming to the formal definitions, so formal definitions is the heart of ontology implementation, and it needs a solid class structure and well-defined relationships among them. So to create formal terminology, I used triplets concepts. So in the triplets concepts, there are three terms that we use: subject, predicate, and object. So subject and object represent or classes that represent domain and range, and predicate is the relationship among them. So following, these are the triplets that I developed in this ontology. Woman is a pregnant woman. Pregnant woman carries fetus. Pregnant woman has health condition pregnancy, and pregnancy has signs and symptoms. Signs and symptoms evaluate findings. Findings indicates normal or abnormal. Fetus as accessed by gestational age, and gestational age evaluate findings. Findings recommend action plan. So to visualize and to make a progress in the ontology, conceptual diagram is commonly used to represent the predicate. So this is the conceptual diagram I built in this study, and it took me nearly 3 months to build this conceptual model. So up to here, I successfully built the logical ontology model. So the next step is to transform the logical model into formal structure. For that, I used Protage 5.5 as an editor tool. So the next step is classes, definitions, and objective properties. So this would be the picture one would be the Protage screen. Sorry. The picture one would be the Protage screen. And here these are the class structures where there are classes and subclasses combined together with is a relationship. And these are the annotations where it is also known as informal definitions, and this would be the formal definitions. And the second is the objective properties. So properties are of two types: objective properties and data properties. So objective properties here, this is the predicate, and here I used domain and range, domain and range to predicate. So for example, pregnant woman carries fetus. So pregnant woman and fetus are the domain and range, and carries is the relationship between them. So the next is Protage validation. So I used a reasoner to check the validancy and the competency of my model, and to see if my model shows the outcome as we expected or not. So for that, I created 6 small questions and converted them into DI query formal description language. So the first one is: pregnant woman has symptoms, cramps on week 13. Is it normal or abnormal? So when I converted it into a DI query, my reasoner shows it's abnormal. And the second question is: pregnant woman has symptoms, severe stomach pain, and decreased body movements on week 19. Is it normal or abnormal? So my reasoner showed it's abnormal. Third question: what are the signs and symptoms of week 13 gestational age? So my reasoner shows that symptoms like nausea, vaginal discharge, food cravings, aches, etc. And the fourth question: does severe stomach pain and decreased body movements are normal or abnormal irrespective of gestational age? They are abnormal according to my reasoner. So which gestational week does have symptoms like nausea, vaginal discharge, food cravings, aches, morning sickness, mood swings, tenderness, frequent urination, or on full swing? So the answer would be week 13 gestational age. And sixth question is: does morning sickness and food cravings are normal or abnormal during pregnancy? So the reasoner shows normal. So with these 6 questions, I was satisfied with the model, how it is working. So finally, conclusion, limitations, and future work. So the conclusion, in this study, we developed a model using Protage, and I used a standard process to create an ontology. So in the development process, we first defined a scope. with which we considered using top-down approach. And this knowledge model I created is reusable and shareable. So one of the main limitations that I came across is the building a conceptual model, which nearly took me 3 months. So that is one of the major limitation that I came across. And the second one is, even though this model has a strong foundation, but it needs to be a little bit tuned up to meet the professional standards, the future work. So the model constructed in this study was a pilot version, and it can be implemented into a big picture using professionals. So while constructing the knowledge model, we created a few instances, but it can adopt several number of instances as well. So these are the references that I used, some of the references that I used. Thank you. Any questions?
Thank you, Lavanya, for the excellent work that you have done.
Thank you, Dr. Jones.
Can you quick explain to us what you learned from the project, because you were unfamiliar with ontologies and knowledge representation? Can you quickly explain in one paragraph what you learned and why an ontology is important
So
to some other approaches?
Yeah, so before starting the ontology, honestly speaking, I don't even know the exact definition, but after reading few research articles and suggestions from you, so I built a conceptual model. My first conceptual model was a disaster, and then I built like 15 knowledge models. So that's how my experience, and that's how I adopted to the ontology and how it works and what is the process and everything. I used ontology, and I personally use this ontology because it manages content more effectively and maximizes the findability and discoverability of the information, and also increases the reusability. So that's why I used ontology over the other things.
Thank you. Lavanya, I would not say it was a disaster, because if we didn't have, we couldn't start and critic and revise. Yeah. So I would never call it a disaster. We have a starting point everywhere.
Yeah. My first conceptual model was like 15 pages, and that just constricted to half page. It took me nearly 3 months to get to that point. So yeah, thanks to you and Dr. Kanita for that.
Anybody else questions for Lavanya?
So how do you compare this, your Protege model, with, say, a dictionary based model or dictionary based thing like the SNOMED dictionary? How do you compare them or map them? Like, how would you finally implement this in, say, an EHR or related to EHR data?
This model can actually help. So it provides a findings based on the criteria of symptoms, fetus, and health conditions, and it takes up the first time pregnant woman data and predict the pregnancy conditions based on the available data. So I hope that answers your question.
Now, how do you relate it to map it to, say, SNOMED CT dictionary?
You looked at that, Lavanya, early on.
Sorry, Dr. Jones.
You looked at that early on at SNOMED CT in your first weeks.
Yeah, I mean, I thought of like linking up with the SNOMED, but for that it needs a whole set of new standards and whole set of new ontology model. So that's why I just stick to the knowledge model instead of SNOMED, because that needs a lot of standards and a lot of rules and everything.
Okay, makes sense. Thank you. Are there other questions? Okay, I don't think there are any other questions. So thank you so much for the excellent presentation. Let's have the next person come in. So Akanksha Pathak, are you there in the room?
Yes, yes.
Yeah, could you please share your screen
Yeah,
and begin your presentation?
yeah. Can you see my screen, everyone?
Yes, we can.
Okay. And can you hear me clearly?
Yes, we can.
Okay. Thank you. Hello, everyone. This is Akanksha Pathak, and my topic is a hybrid prototype to assist individuals with dementia in daily living. So basically, talking about the background of my study, it's based on dementia. So the purpose of the study is to propose a prototype in an integrated form for dementia patients to assisting them in their daily activities. As we all know that dementia is a word which we can, give to a set of symptoms affecting thinking and brain function, and the loss of cognitive functioning in which people lose their ability to think, remember, or reason. So talking about the individual will not tell them the patients, will tell them individuals. So individuals with dementia usually forget, according to the stages, they usually forget the small things in their daily life. So here we are focusing on the activities of daily living, on which my prototype is based. So for example, if a person is using a mobile phone, the individual with dementia can forget the password, or the application, he can get confused with the various applications in the mobile phone, or he can forget the device itself. So one needs to be reminded repetitively for the tasks which he or she needs to do in daily life. So various studies display the evidence to prevent that the physical and cognitive decline. Involvement of technology plays a crucial role. Now, in severe stages of dementia, obviously caregiver is must, and the assistance of the caregiver is must. But the intervention of technology gives them independence to do certain tasks on their own, and which makes them satisfied to some extent. So the intervention of technology has the capacity to provide the solutions to the barriers and challenges that individual living with dementia experience in their daily lives. Now, talking about the challenges in their daily living, as I already mentioned, that forgetting passwords, the names, or the device itself. So during the middle stage of dementia, here we are talking about from the early to mid stage. So during the middle stage of dementia, it becomes difficult to think appropriately and convey the thoughts, what exactly the person needs or wants. In addition to this, it's challenging to perform the daily routine activities as discussed. So also the significance and opportunity for providing the independence is must. Now, several technologies interventions are developed, they already exist, and they are introduced for the functions like safety, therapy, security, and memory. For memory, there are several reminders kind of technology. For security, there are fall detection technology, motion sensor, bed alarms. For therapy, there are music applications, and for safety, there are GPS trackers, which we'll talk about now. If a person is unable to perform any task, he or she might be worried and anxious sometimes. So setting up a daily routine might help the individual making their day relaxing. So for example, there are a few things which generally a person, even with dementia, can remember. So that's the irony that, for example, if we show the individual with early to mid stage that what here's the toothbrush and here's the toothpaste. Now we are thinking, and he is capable of putting that toothpaste on the toothbrush appropriately. So these are the general thing. And other than that, if a technology has a tick mark on it, so we think that the person already knows that if there is a tick mark on the technology, it's basically telling the accomplishment of the task. So talking about the activities of daily living, these are bathing, feeding, like eating, toileting, dressing, etc. Now, we have already talked about the technological intervention. This picture tells a lot about the study that a person, what a person needs help in, that where is my bed, how to turn the lights on, did I take the medication, is this my daughter, what is the name of my husband. So these are a few technologies which I have made a concise list of the several technologies that already exist. So we already know about the pill dispensers that dispense the medications at the appropriate day and time, and it alerts that are allowed up to 30 minutes. And we are talking about a particular pill dispenser, so it would be a tamper resistant for the usage of individual with dementia with the locking system, so that the medications cannot be altered. Now the disadvantage is that the reliable person needs to refill it, and there are also limits in the amount of the pills that can be contained in that. So then here is a mobile application which reminds the individual to take the pills and drink water, turn off the light. So the advantages are that it helps to track the activities, to walking and eating and everything, taking the medications. But again, the disadvantage is that the person can forget the password or misplace the device itself. Now, another innovative technology that has been used is smart glasses. These are wearable computers. Um, they have the features of visual reminders, and they are displayed right on the screen. So it has the feature of face recognition, which is an advantage, and it shows the picture of the medication bottle when a person has to take the medication, and it can also be customized with the light conditions like bright and low, and the battery life can be issue, and the person can forget or the glass can slip off. Another is sorry, I'm really sorry. So another is Sparrow robot. So robots are also used in dementia for a therapy purpose. The Sparrow robot is a pet design. So it has a voice recognition, microphone, and functions of learning, artificial for comfort and touch. So this helps in reducing stress and anxiety and promotes the social engagement. The issues might be cost and ethical, and difficulty in cleaning because it has fur and it's not washable, and they feel embarrassing. So the person, we need to really think of a technology that a person doesn't feel embarrassed to use it, because if another person is looking at the dementia individual, another person is looking at the dementia individual, he or she feels embarrassed that he's talking to a toy, because somewhere he or she knows that this is to make kind of therapy to them. So now, why these technology I have mentioned here? So the disadvantages of these technologies help me to create an idea in an integrated form of a prototype, that what all can be done to integrate such technologies or these drawbacks, and come up with one device that can do multiple, that can help the dementia patients in doing the multiple tasks. So, but also there is no one best technology. Earlier, I have written in my objective that I need to create a prototype of an ideal technology. So then I got to know with the literature review that there is no one ideal technology for and the individuals with dementia. There are several according to their needs and requirements. So I propose an idea of a wearable technology, which is similar to the iWatch. And the features include calling, reminding, tracking, and alerting. The reminders will not be, this is just an overview. I will be showing the prototype itself. The reminders will be not in a mundane beep sound. So the mundane beep sounds can really, create a burnout of frustration in the individual with dementia. So the sound will be pre-recorded by the individual loved one to wake him or her up. Let's look at the prototype itself. So this is the image of my prototype. To create a user-centered assistive technology for dementia care, we should prioritize to focus on the relation, task, and understanding of the person and their situation. Why this I have written, because this is the basis of my prototype, because it focuses on the relations, their understanding to their daily activities and their to-do tasks. So the prototype has 4 icons on the main screen. Let me open the prototype link. Can you all see this? Hello?
Yeah, we can see the
We can
Yeah,
see
okay.
it.
Sorry, because it's another tab. So the main screen has the 4 icons on it. First is of calling, second is of to do, third is of time, and fourth is of music. So here the first icon shows the picture itself of the loved one of the individual, not just the icon of a phone. So which will be really interactive for the dementia patient to remember the face and to remember the relationship of that person to reach out in the emergency situation. Now, when is the time for waking up, it will display clearly the day, the time, and the date with the icon. Now, this is assumed that, obviously I told that the caregiver will be customizing this in the pre-recorded voice. So when it's the time, so for example, the daughter will speak to the father who is suffering from dementia that, hey dad, it's time to wake up. Now, this is working on just by a tap. So now this, with the help of this GIF, it is displayed here that the person, how he needs to put the toothpaste on the toothbrush, and he'll tap again. Now here comes, I'll show you this. So these are the 4 screens of the directions. Now here comes the inclusion of a sound tag, which helps the dementia patient to direct towards the place, or so if it's a kitchen or a washroom. So the sound tag will beep there in the washroom. For example, if a person has to take a bath, so the sound tag will beep there, and the person will follow these directions and move towards the washroom. So if he has to take the left or right, and now when he will reach there, it will show the next task to do for a few seconds. And when he is done with the, because we are providing the flexibility, so and they can do these tasks at their own pace. So when it's done, they'll tap it and it's done. Now the second to do task or the activity will be displayed in the form of GIF again, as the bar tab is shown here. Now when it's time for lunch, a realistic image of the kitchen or the meal can be shown, and again in the pre-recorded voice, the patient will be reminded to the individual will be reminded to take the breakfast. And here also is the option for snooze, for providing a proper interval of time. Now showing the picture first, and then the sound tag will play in the kitchen. And following the directions, the individual will reach to the kitchen. So when he has reached the kitchen, and again the GIF will show the picture of the kitchen, and when he is done with the lunch, he can tap. Now, this prototype also provides the function of the leisure activities. It depends on the requirement of the individual, that he or she needs to loves to read or listen to music. So the pre-recorded voice will remind them that, hey dad, it's the time to listen to music. So the person will tap on music and the music will start to play. and he can choose between reading or music or any other task. And if the person is unable to select or the book, or unable to select, unable to reach to the music device, there is an option to call the loved one. So here is the icon that found the book, or call the individual.
Akanksha, we are enjoying the prototype. Okay, I think you're
Yeah,
done with
it's
time
done.
with this
Yeah.
photo. Thank you.
Okay, sorry. So I cannot speak. No.
No, please continue. Please finish.
Oh, sorry. So yeah, these are the limitations that because there are several technologies. So the hypothesis was that the person is, healthy and has no vision or hearing problem, who is the user of this technology, and it's waterproof. The study unfortunately is incomplete due to the delay of the IRB approval. We couldn't validate this prototype. And proceeding with the literature review, wearables are convenient and safe to use. Although this conclusion is based on the limited resources, more studies need to be done in this area to lead towards a better conclusion and ideal technology. Although there is no ideal technology, as different patients have different requirements. So future scope will be of my prototype is that providing independence to the individual. Dependence on the Wi-Fi, this device doesn't work on the Wi-Fi. It basically works with the sound tag with the help of the Bluetooth. So it can be really beneficial in my opinion. Unlike several technologies, it's like not dependent on Wi-Fi. And better quality and innovative design. So a person doesn't have to run for different multiple technologies and depend on them for reminding and for the safety purposes. This one device can has the capability to help them with several tasks. So, questions?
Yeah, thank you so much, Akanksha. It was a wonderful presentation. The prototype looked very, very interesting and cool. Any questions from the room?
Akanksha, first of all, congratulations on the work that you have done. So Akanksha got the charge from the American Alliance for Dementia to come up, to look at what exists for dementia individuals with dementia, and to look at what can be used and made more common so that they don't have to remember all those things from, we even know how many logs in, how many different buttons. The screen design is so different. So that she started with her table, what was already an excellent work. And then she came up with the design of the prototype, what she is going to test in the next week, because we had problems with the IRB, but she will test it. Akanksha, do you think that the small screen will be working, or can we also do the prototype on tablets or TV screens?
Actually, the reason behind the wearable was that only it can be like not comfortable to look at the images or the GIFs in the small screen, but I've made sure to include the colorful images or the GIFs. And if this is included in the screen or tablets, again, there is a drawback that a person living with dementia can forget the device. So that's why I came up with the idea of wearable.
Mm-hmm. Thank you.
Thank you.
Anybody else a question for Akanksha?
Yeah, so do you also think that something like a vibration on the watch for alerting, or some other way to notification would probably get more attention?
Yeah, actually, because the idea behind this prototype is that the individual has to wear it for a long period of time. The vibration would lead to burnout or frustration in the individual with dementia. And instead of the mundane beep sounds, music is incorporated in the device, so that, to answer your question, that he or she doesn't feel boring while getting the alerts. Does that answer your question, Prabhu?
Yeah, and how do you think like caregivers or family members would be able to participate in this? Like, how do you think they would be helping or supporting the
Yeah, so
patient?
so caregiver play a major role in customizing this prototype because they have to give their voice as pre-recorded voice in that device. As I said that, for example, if it's daughter, so daughter has to give the voice, and then in the morning the alarm will say that, hey dad, you have to wake up. So caregiver plays important role in this prototype too.
Yeah, but
Akansha, in
beyond
addition
that,
to that question, I would add, could the caregiver get the feedback if the activity is followed up, yes or no?
Yes, because it's like in emergency situation, like the individual can call the caregiver. So yes, they can keep a track. So the basic idea was to perform the limited activities which can give the independence to the individual. So the caregiver can keep a track, obviously, um, by the calls. And so basically the hypothesis is that if the caregiver leaves in the morning and comes in the evening, so within this time period, any activities which can be performed by an individual can be performed independently. So the caregiver does play a role in this way. Sorry if it did not answer.
no, thanks so much. This was very engaging, and we could probably go on for another 10 minutes, but we have to move on to the next student. Virendra, are you there in the room?
Thank you.
Yes, Professor. I'm
Thank you,
online.
Akanksha. Thank you, Virendra. Could you please share your screen and begin the presentation?
Good afternoon, everyone. And my project is on patient portal usability and utility exploration. So patient portal is a secured website that will allow. Hello.
Yeah, sorry, there
We
was some
lost you.
disturbance. Please continue.
Yes, sir. The patient portal is a secured website that will allow the
Also,
patients
sorry,
and
could you please switch your view? So switch the presentation view. Thank you.
all right.
No, sorry, I meant on the screen. On your laptop, we are seeing the presenter screen and not the actual presentation screen. Like if you click on display settings, you should be able to switch.
Yeah. Did it switch, Professor?
No, it did not, but I think you can continue. That's fine. Thank you.
Now?
Yes, that's great. Thank you.
Yeah. Yeah, Professor. Like the patient portals, mine is about the usability and utility exploration. And coming to the patient portals, they are like a website which gives access to the patient as well as the providers to view, download, and uh, store and do many tasks with the patient data, like the personal health information. And this patient portals allows a lot of options for the patients, like it will allow the patients to schedule appointments, clinical visit summaries, read the medication and the lab results, etc. And the patient portals, why they were backed up by the meaningful use, and the healthcare organizations which maintains these patient portals were incentivized by the CMC. And coming to this meaningful use, like patient portals uh, were mentioned, were required to maintain all the three stages of meaningful use. In the first stage, like which happened. Uh, at least 50% of the patients must be able to download the PHI within 4 days after the clinical visit. And the second stage specifies like the patient web portals must be at least accessed by 5% of the total patient population, whereas the meaningful stage 3, uh, it focuses on the complete transformation of the patient portals to the APIs. So this way, like a CMC and meaningful use makes the patient portals uh, makes the patient to more engage with the personal health information. And coming to this, like there's a lot of investment is going on from the government side, and like endorsement is being done. Even then, it is found that only less than 30% of patient portals are being utilized. And like the reasons for this underutilization of the patient portals were attributed to both the patients and provider barriers. And like I need to explain the context for this project. Like IQUIN, what is called Indiana Quality Improvement Network. It has it has relation with 26 healthcare centers in Indiana, and their main mission is to understand and improve the patient engagement. So they have collaborated with SYC to understand the barriers that preventing the underutilization of the patient portals. So the primary goal for this project is like development and validation of two questionnaires, like one for patients and the other one for providers. And for the patients, patient digital access, digital literacy levels, and their preferences, like with the portal and its functionality, uh, what to be included. And for the providers, it is like to analyze what factors or the what barriers that are preventing the lower utilization. So based on the literature review, like the literature review was done on PubMed, Google Scholar, Ovid, and based on the literature review, like uh, uh, patient barriers were able to were identified, like the demographics, age, gender, like for example, if you take age, uh, the youth are more like they were having some accessibility and availability of the technology, and they have some interest. So that's how these demographic factors will impact. Next to demographics, we patient personal factors like the availability, the digital literacy, availability, accessibility of the technology, and perceptions like the security and the privacy concerns, etc., were also were also identified. And the final set of patient barriers were like which are specifically which were specifically for the patient portal familiarity and functionalities, which is like what they were informed about the patient portal is like they were endorsed, or they know all the functionalities of the patient portal, and if not, what was the reason they were not using the patient portals, like the specific barriers were recognized from the literature review. And for the providers, the main reason, like from the literature review, it was observed that their personal interest and motivation for the use of patient portals was the primary reason, towards the lower utilization of patient portals. And they were having some you know uh, perceptions like perceptions towards the patient and perception towards their practice. And coming to the results, based on these barriers, a questionnaire, like two questionnaires, one for the patients, the other for the providers, like a draft was designed. The patient questionnaire is worth 27 questions, whereas the provider questionnaire is worth 20 questions. And during the survey, like this questionnaire development, bi-weekly meetings used to happen with the mentor as well as with the IQuint team. And after series of reviews with the IQuint team, mentor, and even sometimes like the affiliated healthcare centers, the questionnaire was reduced from like the patient questionnaire and the provider questionnaire was reduced to 10 questions to make the survey taker engaged, and make it like survey completion easy, so that we can get a minimal understanding of the barriers that is preventing the patient portals. So after the questionnaire is designed, it was IRB approval for the ethical issues was taken. And this project has been halted at the validation stage, due to COVID-19, and there are many number of surveys happened at the healthcare centers. The healthcare centers asked us to give some time to proceed with the patient portal thing, like what the health centers thought to be a priority in 2020 January became less priority by the end of May or so. So we I have to wait more than 6 months for getting the permissions to at least to get to do some pilot survey with at least 40 patients or 40 providers to understand the barriers, but this not happened. And in the last week, I got mail from the IQuint team that no other healthcare center is going to do this validation like as their priority list has been changed after the COVID-19. So uh, I would like to like if 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 uh, if the priority list is again back, I would like to further continue this study. First, do a pilot and take the reliability, internal reliability quotient, and understand the problems that are, you know, that are associated with the questionnaire and change the questionnaire and make it a bigger survey. This is the theme what the project is meant for, but this has came to halt uh, at the early stage. So coming to the challenges, the COVID pandemic is the biggest challenge for this questionnaire, and like the availability of the studies for the usability and utility were very low, and even it is very hard to find the providers barriers, like any literature regarding the barriers. Yeah, like what are the coming to the limitations, like piloting and validation of the questionnaire is not done. So to keep this survey very simple, we might have missed some important barriers, but would you like to see the questionnaire?
We are not able to see the, yeah, okay, it's opening up now.
Yeah, like after making the questionnaire, it was converted to an online version for easy distribution and with the Qualtrics. This is end of my presentation, but I would like to thank my mentor, Dr. Jones, and the IQN team members, Jasmine Page and Funke Oldell, who has really supported to at least to make, who has tried to the very end, like for making the possibility of at least a pilot survey, but it did not work. So is there any questions?
Thank you so much for the presentation. Questions from anyone?
Teacher, when you are going, or what was your plan? What were you looking for when you validated the questionnaire? What do you think were the points that you were looking for? Was it the literacy, the order of the questions? What did you have in mind when you wanted to validate? Because you had to have a sheet to say, oh, then is when I know that the tool is working, yes or no.
Yeah, initially, like I wanted to test for the reliability of the questionnaire with the pilot survey. You know, we can use internal reliability coefficient with the Cronbach's alpha. And once the reliability, like once after the both the surveys reliability is there, based on that, what are the questions that are you know, not performing well, can be identified, and the questionnaire can be changed according to the needs. And that's how, like, after reliability test, we can go further and change the questionnaire according to the needs. Like this questionnaire, that 10 questions, to make it to 10 questions, it has gone several changes. So that way, I'm sure that even these 10 questions, okay, when they went to the pilot survey, I'm sure there will be some inconsistency. People might feel that certain questions will not be very good or irrelevant, and so we can change it, and that's how again a modified survey will come, and a whole new survey can be launched to understand the real barriers, that like the minimum barriers which really impact the patient portal can be understood. And then once those barriers were understood, this project has significance, so that CMC spending is a lot of money on this for meaningful use. And even the hospital, like the healthcare organizations, the hospitals or the healthcare centers, they were spending like a too much amount for the installation, maintenance, and everything. So after spending this much amount, there must be cost to benefit analysis must be there. They are spending like millions of dollars on the patient portals, and at the end of the end of the day, if the benefits are not obtained from the patient portals, it doesn't look, it's not economical, and it is an added burden on the hospitals, where smaller hospitals smaller hospitals, it is really difficult because it takes like 100,000 to maintain technical staff or someone.
Richard, thanks. Thank you. Sorry for interrupting you.
I'm sorry.
Are there other questions before we move to the next person? Sorry, we were already over time, and that's why I had to interrupt you, Teja.
No, we understand.
But thank you for the excellent presentation. I think we'll move to the next person. Jyotsna Shri, are you there?
Thank you, Professor. Have a good day.
Thank you. Thanks. Jyotsna, are you there?
I see her in the group, but there is no activity. Yes, no? Yes, she's
okay.
showing.
Yeah, we
Sorry
can see
about
you.
that. I think my connection. Am I audible
okay.
now?
Yeah, you're audible, and please share your screen and begin the presentation.
Everybody see the screen.
Yes, we can. Thank you.
Thank you. So my capstone presentation, good afternoon, everyone. Sorry. And this is Jyotsna. I'm presenting my presentation on testing the feasibility of virtual assistants to assist people living with dementia and the healthcare givers. And my project is under the guidance of Professor Joseph Jones and Jeff-Nick Jang. And coming to the scope of the study is mainly related to dementia, COVID-19, and social isolation. Dementia is the syndrome that is cognitive, chronic and comprises deterioration.
I don't think, yeah.
According to World Health Organization, around 50 million people are diagnosed with dementia worldwide. And
we cannot hear you, Jyotsna. So you have to come closer to your computer or use a headset.
Middle-income countries. The new cases are increased about 10 million cases every year, and which is expected to have been affected and that affected in different ways, which varies from person to person, depends on the impact of the disease on the person and the person's personality before becoming ill. The coronavirus disease is a current pandemic disease affecting many individuals worldwide. The preventive measures include social distancing measures and movement restrictions such as lockdown, where the transmission can be reduced with restricted contact with people. And here comes the social isolation, the main strategy implemented to protect the public from COVID-19 is which has a potential to impact on older adults and individuals with Alzheimer's disease or dementia diagnosis. Isolation is associated with about 50% of increased risk for dementia. The goal of the study is to determine current technologies used to provide care for people living with dementia and understand ways how caregivers and healthcare workers can provide social support to people living with dementia. The research aims to develop a prototype of intelligent personal virtual assistant that may help to combat the social isolation and physical distancing in people living with dementia and the elderly supporting the caregivers. Coming to the background of the study, to overcome the loneliness faced by people living with dementia, the problems faced by the caregivers due to the coronavirus pandemic, Alzheimer's Foundation of America has taken up a mission to support the individuals living with dementia, families, and caregivers affected in this process of providing care to people living with dementia. AFU suggests that people living with dementia to get engaged with activities at home during the isolation period and include some activity tips using technology. That includes virtual tours, connecting with families and friends using video chats such as FaceTime, Zoom, Google, or by sending text messages, email, and phone calls. AFA is conducting a virtual programming session that further involves the activity tips and caregiver tips to explore technology. AFA have described 6 ways how technology can make caregiving easy. 6 ways include safety, care coordination, cognitive engagement, self-care, health tracking, planning for future. And there's some existing technologies which are helpful for assistance in people living with dementia and their healthcare needs. According to some studies, social assistive therapist robot for people living with dementia can improve cognitive abilities, social interaction, and quality of life. The social assistive robots include robots and socially interactive robots that are mainly used to assist humans through. And some of the social interaction robots include pseudo-animal robots made of mental or synthetic forms, such as Nikoro, it's a robotic cat, and Aibo, it's an artificial intelligence robot, it is a dog, and a Paro, it's a baby heart seal, and a Coach, it is a cognitive orthosis for assisting in activities in the home system, is an assistive technology designed to assist people living with dementia with hand washing. And these SaaS systems will be able to provide detailed reports of the patient progress to their caretakers and physicians to improve the further vision of the care and quality of life. The commonly known devices as personal assistants or virtual assistants are Amazon Echo, Alexa, Google Home, Google Home Mini, Cortana. Iwa. Iwa is a virtual assistant, health assistant, which is recently developed in this COVID-19 scenario and which is mainly helpful for the elderly people, not particularly to dementia, but it is helpful for older adults. And there's another study conducted with to design a video chat system in order to assist with older adults without mild cognitive decline and maintain the social engagement activities. So coming to the methodology, the usability of technology is assessed by using technology acceptance models, the ease of use, their experience towards the use of technologies, and their interest towards the acceptance of the technology. Subjects will be asked some questions regarding their daily activities and the use of technology or assistive devices, how they're coping with social isolation and physical distancing in general. Besides, we will observe some interactions between caregiver recipients during the day and how tasks have been performed. Think aloud approach is used to collect the data where the people living with dementia or caregiver. People living with dementia will be particularly asked to narrate the activities which they are being performed in their daily life, like step to step. And a virtual assistant like Amazon Echo is used to show people living with dementia regarding the usage of an assistant and assess their acceptance towards the technology during the interviews. Contextual data is collected from the patient and caregivers interviews based on their needs and usage of the technology prototype is developed. The prototype can be generalized and that is used to is used by people living with dementia, or it can be individualized based on their needs. The people living with dementia and caregivers are recruited for the study from Jill's house. The eligibility criteria of the study includes inclusion criteria is over 18 years of age and people living with dementia and their caregivers or healthcare workers who are providing care to people living with dementia. Exclusion criteria: subjects who do not understand the English language and children under 18 years of age or adolescents will not be permitted into the study. Discussion and conclusion. According to the studies, virtual assistants use and deployment can offer positive benefits to aging carers and dependent adults, such as people living with dementia, to monitor their daily activities, well-being, and quality of life. The user-centered design may help the aging populations who are familiar with existing digital technologies and internet, which can speed the adoption of technology. The use of robot technology and artificial intelligence are the best models for human caregiver to virtual assistant collaboration. And according to some studies, it is essential to consider preferences of the individuals. Relationship preferences differ from one person to one. And with all the current emerging social engagement techniques, virtual reality has the potential to increase the interpersonal socialization for the people living with dementia. And according to one of the studies, older adults has the interest to use the technology to participate in the social activities. And they used a heuristic evaluation to test the usability of the system and to assess older adults' needs and preferences in using the video chat systems. And use of intelligent assistive technology and virtual assistants by caregivers of those with dementia appears to have potential impact on the lives of the caregivers also. To conduct usability studying, considering values on online platform that supports communication and collaboration between family, professional caregivers of people living with dementia. And according to a study, there's some technology acceptance models in health informatics that involves technology acceptance model, that is TAM, and unified theory of acceptance and use of technology, that is UTA/UT, which are
You fell out again. We couldn't hear.
From all the studies. Sorry, Professor. Am I audible?
Yeah, you're audible now, but in between you dropped out again. Okay, please continue.
Sorry. So from all the studies and reviews, the use of virtual assistants can improve the quality of life and well-being of the people living with dementia and their caregivers. The design needs to be user-centered and considering the social preferences of their usage of technology in their daily life, as it varies from person to person. The challenges faced for this study is like COVID, because due to the COVID, we are not able to meet the persons, people living with dementia or caregivers in person to have the interviews and IRB approval. We almost took about 6 months to get the IRB approval for the study, and we just got it last week. And so I still not start my interviews for the study, so I don't have any results for the study. So I'm going to start the interviews from next week, and we started recruiting the people living with dementia and caregivers. And maybe one more challenge after interviewing, maybe I think interviews with people living with dementia is also going to be a challenging one. And limitations of the study is the study is only limited for a particular assistive community due to the lack of act. And as of now, recruitment, we have very small sample.
I think we lost you again. Jyotsna, are you there?
Yeah, I couldn't hear the end of her presentation.
Oh, I'm sorry, Professor. Which part? Like,
I think the end of the presentation, that's okay. Do we have any questions for Jyotsna?
Yes, thank you for the presentation. We all know that your study was prohibited first by COVID in the fall semester and this semester with the change in IRB to get IRB approval.
Mm-hmm. Yes,
so
Professor.
Can you explain a little bit to us, what do you need from the DIET patient caregiver in order to build your conceptual model for a virtual assistant?
Yes, Professor. Okay. While interviewing the patients, we would be taking their considering their daily activities and their communication details and how do they communicate with people, like socializing with people, and what type of technologies they use in their daily routine. If so, based on their acceptance, so we will be asking like what exact technology they will be using. I'll be asking like what exact technology they will be using, and based on their usage, if they want any upgrade in the technology, like whatever they're using, if they want any additional features for the technology which are they're using. So based on those details, we'll be developing their conceptual model.
Other question that I have, can the virtual assistant be built in the prototype that Akansha showed us?
Sorry, Professor, actually, I just got lost. Can you repeat the question?
Sure. Akansha showed us an excellent prototype of technology that could be used by individuals with dementia. Do you think you could integrate your virtual assistant in that prototype?
I don't think so, Professor, because like, of course, she is doing it on a basis of her daily activities and considering all this. But my thing, what I'm thinking is like to consider their user acceptance first to the technology, like how they will be using it, how they will be
We lost you again.
Yeah, I think we lost her video as well, and maybe she dropped off.
Yeah, I think, yeah, it's not, if you can hear us, I think it's to consider that, because even if there's activities of daily living, there are maybe some things that need, like she had the music or other activities that the patient want to do. That could be a very good tool to connect it to there and include the virtual assistant there.
Sorry, Professor, I just lost in my laptop, so I just can't connect it through my phone.
But I think you can hear that conversation later. I mean, the comment that Dr. Jones made, I'll make the recording available. So just now you can hear that and then maybe respond to it over email or maybe over in your report, maybe.
Yeah, sure. I will email it to you too. So Akansha, can you quick comment on that? What do you think about that?
Akanksha, are you there? Okay, maybe Akanksha is not here too, but let's move to the next one. Thank you so much, Jyotsna, for the presentation. Let's move to Nishant. Nishant, are you there? You're muted.
Hello, Dr. Jones. Hello, Dr. Purkest. I'm sharing my screen. Give me a minute. Yeah. Oh. Is it visible? Oh, sorry. Is it visible, Professor?
Yes, we can see it now. Thank you.
Yeah. Okay. So, hello, everyone. My project is categorization of a dementia patient according to their needs. And I worked on this project under the guidance of Dr. Joseph Jones and Dr. Enming Zheng. Now, moving ahead to the problem statement, dementia patients have very specific needs based on their symptoms, and their needs remain unmet due to the gap between the caregiver skills and the needs of the patient. It gets difficult to understand the needs of the patient and how much care they need. This leads to an additional stress in caregiver's mind, and patient progress is not properly measured. So in this presentation, we will be looking at end-to-end journey of the project, starting from understanding about what's dementia, objective of the project, methodology, future direction, conclusion, including the learning from this project. Coming to the dementia, what is dementia? Dementia is a serious health condition which usually occur in older people and leads to memory loss, cognitive disability, and loss of thinking. It is the most common form of Alzheimer's disease, and it is caused due to brain cell. Some of the common challenges which people living with dementia face are forgetting the meals, forgetting the wallets, like things where they have kept. The symptoms of Alzheimer begin slowly and they gradually get worse by the time and age. Looking at the sum of the key numbers, around 6 millions of Americans are living with Alzheimer disease, and 1 in 3 senior dies with Alzheimer or any other type of dementia. Now, objective and scope of my study. So the objective was to collect the data set and analyze the dementia needs from the literature and interviews. As there is a delay in my approval for the IRB, so the interview session will be conducting this coming week. So I made the dashboard on the basis of the literature for now, but there will be few changes once my interview session, one-on-one interview session with people living with dementia and their caregivers is done. And the second part is you need to create the dashboard that can help the healthcare provider understanding the needs of the patient based on their symptoms. The scope of the project is to reduce the mismatch and improve the health outcomes of a people living with dementia. Now, moving ahead to the methodology section, there were 4 stages of the methodology. Literature were collected, reviewed, and information around the dementia needs and symptoms was extracted. Data was collected from literature and the source, and it was merged to be used in a data set. Questionnaire was sent for the IRB approval, but it got delayed and recently it got approved. So the next step will be conducting the interviews with the people living with dementia and their caregivers. In that data set that will be gathered through the interview will be refined and used in the dashboard. Now, these are the results only on the basis of the literature reviews dataset. Still, the results section need to be changed once my interview session is over. So some of the key results of the study were activities of daily living and instrumental activities of daily living, symptoms, and needs were collected from the literature. Dataset was created from the for symptoms, frequency of the symptoms and needs, and embedded into the dashboard. As a result, of functional dashboard was created to identify the needs based on the symptoms. So here is the first section. I made I collected the data set and organized into 2 things, ADL, which is activities of daily living, and second is IDL, which is instrumental activities of daily living. These data set, the language for the symptoms and the needs were quite complex initially. So constantly we had a meeting. So from the feedback of my peers and my mentors, I refined the language of the symptoms and made it more simple and granular. This is the second table for the data set. Now, moving ahead, let's look the dashboard that was created to match the symptoms with the needs. Now, here is the working video of the dashboard. As you can see, this is the dashboard. I hope the video is playing. Yeah, so here's the dashboard. In this, I made 3 colors, green, orange, and red. Green denotes to little or no care, orange denotes to some care needed, and red, high level of care needed. In the left side, there's a symptoms according to ADL and IIDL. If a healthcare providers click on the symptoms, like for example difficulty in controlling poo, there will be more frequency of, okay, if he's facing during difficulty during day, so the need will be popping up stating the green color, that means little or no care needed. Or if he has a problem during day and night, that means a red color will be there, which is an high level of care needed. And if it is infrequent, there will need will be changes and it will be showing some care needed. Keep a check on the patient if they need it. Same as goes for other symptoms as well. For example, limited mobility to go, so during night it is showing green, then coming to it is showing red. Same as for ideal section, if a person having difficulty in driving and remembering the routes, sorry, during the day, during the night infrequent, so the color coding will be doing the same thing. And once I get the data from the interview section, I will make the changes, and they at the end of the dashboard there will be a summary created. Okay, so the care which is coming, like the symptoms, according to the symptoms the color coding is there, and this color coding will help me to make the summary of the patient, that what level of care is needed. Yeah, sorry, yeah. Now moving to the beneficial, how it is beneficial. This dashboard helps to solve the problem. The dashboard will definitely the dashboard will identify the needs so that the right caregiver can be assigned since the beginning, and will reduce the mismatch between the caregiver and the patient. When the caregiver will understand the needs, this can potentially improve the patient satisfaction. Based on the frequency, the caregiver will know where to keep a watch, and if there is a need, if the needs are changing. This will facilitate the improved outcomes for the patient, and progress of the patient can be measured. The future direction for this, the interview will be conducted with people living with dementia and the caregiver. The dashboard can be used by the healthcare providers and the caregivers, and evaluation should be done to assess the functionality. Based on the feedback received from the providers, the dashboard can be improved. Moving ahead to the conclusion section, the biggest challenge of the project was to receive the approval from IRB. And second challenge will be, once we'll have an interviews session with people living with dementia, we have to be very precautious, asking them the question, that any question doesn't hurt them. So it will be, we have to be very precautious towards asking the question. And the limitation of the study was to that we have to rely on the data collected from the literature review, as the interview got delayed. Once that thing will be over, so we can, I think I can make some changes. And another limitation which I found is the data set was limited as for my understanding. So I was not able to create a big data set. Key learning from this project, I've like one thing I've understood from this project, that different like the people living with dementia has their different need. So with the data sets, we wanted to ensure that correct symptoms are collected from the providers to provider for the best recommendation. Yeah, thank you so much. Any other questions?
So
Thank you, Nishant.
Yeah, thank you, Professor.
Thank you, Nishant. Thank you for the excellent presentation
Thank you,
and the work.
Professor.
Can you explain to all of us who are the caregivers that work on the front, and what is their education level that explain the gap in skills?
So, Professor, like as my understanding, the caregivers will be it depends person to person, but they should know the basic needs of the people living with dementia, and surely the dashboard which I created will help them to enhance and know the patient quite well, so that they can. They can start their works initially, rather than, because sometimes it take very like so much time to like a caregiver to understand the needs. So sometimes the process get delay. So probably this dashboard will help them to get the needs early. And if the caregivers are like have a basic knowledge of the dementia patient, this dashboard can help them to know more about the patient according to their symptoms.
Thank you. Anybody else? Suggestions?
Thank you, Professor.
Yeah, so thank you for the excellent presentation. It looked very interesting, but
thank you,
I think I'm wondering how the interaction with clinicians would take place. Like, how would clinicians participate in help designing this?
So Professor, like this dashboard will be like the healthcare providers where the caregivers has been assigned. So the healthcare providers will be using this dashboard so that they can match the best caregivers with the people living with dementia.
No, so I meant in the
Sorry.
design process of this tool or this dashboard. How are you involving them in it?
Once I didn't involve exactly, but yeah, surely once I will be completing this dashboard, I will be taking their feedback that are they comfortable with the dashboard, like the dashboard is easy to understand. I hope the color of the dashboard is not that the dashboard is appealing for them, they can easily use. So once it will be there, I will be surely taking the feedback from the healthcare providers and I will make the changes according to them.
Nishan,
is there a conceptual model on which you're going to base that? Sorry, Jones.
Yes, no. I think you asked my same question.
Not exactly a conceptual model, but from this I can make one. For now, it's not any conceptual model with me, but yeah, surely I can make one.
So, Nishan, you have to explain that you built the current model based on the literature review and your conversation with people working with dementia.
I make you're right, Professor. Like this dashboard, I like with the help of the literature and people with like working with dementia. Like we usually had a meeting, like every week meeting with a metrics care person, like people who are working on this. So I took a feedback from them, not from the providers, so that I can make it more like better and more reliable for the providers and the health caregivers.
Yeah, that's what I understood. And so my question is really, how would you involve providers in it? But thank you so much for answering that. And thank you so much for this great work.
Yeah. Thank you so much, Professor. Thank you so much, Dr. John.
Do we have any other questions from the group?
And Ming, do you have some suggestions?
I think it looks much better than the first one I saw on Michan. So great work. I don't have any particular questions. Thank you.
Yeah, thanks to you and Meng as well. Your valuable feedback helped me a lot to improve the dashboard.
You are very welcome.
Yeah.
Okay, so thanks, and let's move
Professor.
to the next presentation. The next one is Charishma. Are you there?
Yes, Professor. Sharing my screen. Good afternoon, everyone. My project is about feasibility of differentiating physical activities in individuals without movement disorders using the biosensors under the guidance of Dr. Jones, Jai Patel, and Dr. Saptoshi Purkayastha. An introduction: physical activity is essential in everyday life as it would reduce the unwanted consequences of healthy group and the people with the movement disorders such as Parkinson's patients. There are many misinterpretations that vigorous activities would improve the health, while others think that low intensity activities are sufficient. So there is a need to increase the awareness as it improves the health and slows the progression of diseases. And nowadays, to track these physical activities, many trackers are available, such as smartwatches, in which we have Apple Watches, Fitbit Versa, and also we have accelerometers. So compared to the sensors, smartwatch trackers have some drawbacks, such as providing constant new updates of tracking and have some error rate in the data. So these variable sensors are helping in tracking the activity moment over an extended period of time and collect the real-time responses from the users effectively. So this study have analyzed the physical activities on the healthy group first and plan to compare it on the people with the movement disorders further. The main primary goal of this project is to develop a machine learning model for validating and classifying the activities that the healthy people perform. And the short-term goal is to examine whether the sensors can help to identify and track the various whole body workouts in healthy people. And this study is approved by the Institutional Review Board. And we have used Biostamp RCTM MC sensors. This system collects and processes the raw data into recognizable clinical metrics using the accelerometer, which will measure the velocity and the position, and the gyroscope, it will measure the orientation and the rotation, and the electromyography, which will measure the cardiac activity. So we have contacted Rocksteady Indianapolis, where the Parkinson's patients perform non-contact boxing. In order to compare healthy with the PD patient, we have finalized only those cardio and non-contact boxing activities they perform and selected the most common and repeated ones. Inclusion criteria includes the subjects over 18 years of age and do not have any movement disorders. In the exclusion criteria, the subjects who have any health condition that would put the person at risk due to physical activities, or have any kind of skin condition that would not allow the use of sensor patch, and individuals who have minimum movement ability are excluded from the study as they may not perform the project task successfully. And the students from Indiana University are contacted by using the recruitment materials such as flyers. And the team has provided detailed information using the phone calls, emails, or directly based on their approach. And this study is performed in National Institute of Fitness and Sports, Indianapolis, where the subjects have to attach 3 sensors, as you can see in the figure, and on the various body locations. First location is on the chest, and the second is on the arm, dominant arm, and the third one is on the leg. And before starting the study, they have filled the pre-exercise health screening questionnaire to ensure that they are healthy enough, and each subject have a unique identifying number, and they were allowed to take frequent breaks as necessary after each and every activity. And simultaneously, we were recording the activities with de-identifying techniques such as blurring the participant faces and muting their voices to ensure that the sensor data is validated by the correct physical activity. All the data points collected by the sensor are stored in the secure encrypted server as part of the endpoint system. After all the activities are performed, recording was stopped and the sensor data was directly synced to the Biostamp secure cloud, and it was downloaded from the investigator portal to perform the cleaning. The data, we have the sample size of 8 subjects, and the variables in this data set include timestamp, acceleration of hand, leg, and chest, and the gyroscope has both the hand and leg values, and also sample which consists of electrode values. Python tool was used to perform the analysis. To extract the data and clean it. Physical activity instances were monitored while collecting the data using the smart stopwatch by noting the starting and ending time of each activity, and video recorded them. So each person data was collected in EST time by us, but the sensor data is recorded in UTC time. So the data was cleaned and the timings were converted accordingly for each participant, and assured that it has no missing data, special characters, or any kind of duplicate rows, and merged all the chest, leg, and hand data set into one CSV file. We have plotted time series charts of both the acceleration and gyroscope values to visualize all 33 activities performed by the participants. As you can see in this plots, we can see the variation in each activity, and they have performed so many activities using stepper and the scooter, cycling machine, and heavy weights. And also they perform non-contact boxing, such as hips, uppercuts, punches, and punch down, and hooks. The model which is implemented for analysis include, this study has applied multiple supervised machine learning algorithms. Each classification was performed twice with and without electrode values, as it is different from the acceleration and gyroscope. At first, I have implemented k-nearest neighbors for the target variables, and the algorithm was run few times with different k values to choose the k value that is right for the existing data. Secondly, we have plotted the conditional probability of error rate versus k value to avoid the confusion, and selected k value is equal to 5 because when I'm increasing the k value, the error rate was increasing in the graph. So that is the reason k value of 5 was selected. And the second model that was implemented is random forest model, support vector machine, naive Bayes, and the logistic regression. Metric used to evaluate these models include accuracy and F-score values. As you can see in the results section, this classification reports summarizes the results that are obtained by using the supervised classification algorithms. KNN and random forest models have given the best classification reports with accuracy above 85%, and the macro and weighted average F scores were above 80%. And the support vector machine is the third best model. It has an accuracy of 81%, and the F score values are above 76%. However, logistic regression and naive Bayes models performance were very poor with less than 50% accuracy. And this is the classification results of hand, leg, and chest ASL and gyro values without using the electrode values. And the KNN and there are almost similar results with only slight differences in accuracy and F scores. Both the KNN and random forest perform well. And the support vector machine has an accuracy of 78%. As mentioned before, logistic regression and naive Bayes have performed very poor. And it's the point to be noted from this study is these algorithms have classified all the cardio activities well with above 70% for the precision, recall, and F score values, but the non-contact boxing activities were classified with very poor precision and recall values. Discussion. Several studies have been performed by focusing only on analyzing the group of individuals using a single accelerometer on the wrist or thigh, and few studies have used them on the chest, thigh, and ankle and perform only limited activities such as walking, running, sitting, standing, and ascending stairs, lying down, daily routine activities, and the treadmill. However, this study has taken a different approach to determine and evaluate the cardio and non-contact boxing activities using the real-world data set, and the results demonstrated that all algorithms developed for all the data points has more accuracy when compared to that of the only acceleration and gyro values. And this study has collected both the raw data and the video recorded activities. So it is also possible to perform the post-study analysis such as comparison with any other different monitor and algorithm tuning. And we identified that it is feasible to use machine learning models such as k-nearest neighbors and random forest model, as they have accurately classified all the activities. And the proposed method using biosensors can be applied for physical activity monitoring system, which will create the awareness about the physical activity up to the individuals and promote the healthy lifestyle among both the movement and both the healthy and Parkinson's patients. We also hope that this data set can be used as a standard and would serve as a basis for the foundation for the future research in comparing this with the PD patient data and performing some correlation analysis between the groups and determine the best accuracy that could predict the PD patient using the sensors. And the future directions of this study might be of interest to the students, researchers of several disciplines. And the limitations of this study include the sample size was very small and only limited to 8 subjects because we have only few adhesives available while we are performing the study. And the data set has only, more males than females, and the individuals are only aged between 24 to 29 years. And from the rock steady boxing, we have selected only 33 activities similar to Parkinson's patients who have performed them because we want to compare this data set with the PD patients in the future. And these are the references. Thank you. Any questions?
Thank you for the presentation.
Go ahead, Dr. Pugayasa.
Yeah, thank you for the presentation. I think it was very interesting. I had two questions. One was about why you had chosen those subjects and how did you choose them? Or what kind of sampling did you perform to choose your subjects? And the second question was, does that make like because they are of the similar sort of body or similar kinds of individuals, does that help improve the accuracy of a model? And if there were very diverse subjects that you had taken, would that make it harder, or what's your guess on that?
I mean, we have selected only these subjects because they were performing activities regularly in the fitness center. So I think these sensors are able to track activities accurately, and predicting, and the models were predicting the accuracy well. Answer your question.
Okay, thanks.
May I continue and ask a question following up? So, Horisma, if we want to see if so, your group is what Dr. Kokayasta pointed out is very, very homogeneous.
Mm-hmm.
And so you were able to detect the different activities in a homogeneous group. Do you think we would get the same results if I asked to do the same activities with a person who is 50 years old or a 60-year-old? Do you think the sensors would be able to detect still the same activities in those different groups that are not as homogeneous?
Yes, Dr. Jones, mainly because we have also performed this on the Parkinson's. The patients were above 50%. So as we can see, these sensors were classifying both the healthy and the Parkinson's disease group activities very well.
So I think that's not what Amruta said to us. She said she was able to distinguish if it was upper body or lower body where the activities were, but she was not able to distinguish the differences between the disease severity and the different activities, if I recollect.
I think it can do it, Dr. Jones. I don't know why Amrita has said that, but based on the comparison, I think it can perform well.
Okay, we need to evaluate that a little bit more, but there is a potential that we can do it based on the approach that you have done.
Yes, Dr. Jones.
We maybe need more other people to sign up for the study. I think there are other advisors that are and mentors that are available. They maybe have some questions too. I think Dr. Patel is available too.
Yes, I was going to ask actually kind of a similar question about the sample, but what you have done is really, it's like the first step towards what we want. We have created this pilot data set, pilot, the algorithm, which is good. Now, my question would be towards your supervised machine learning and your versus your unsupervised machine learning. So let's say hypothetically we have 500 patients data that we have collected. Now, what would you do in order to answer the same research question that you answered? Right now you have 7 or 8 people data, but what if you have 500 people data? Which one would you use? Which one would you try first, supervised or unsupervised?
I think we have to use unsupervised first to do how the activities are, how the acceleration and gyro data has split by doing the clustering. And then based on that, we can use a supervised machine learning.
Okay, so how would you generate the gold standard data set from that? Because for supervised, you would need to have something to compare with, right?
Yes.
So how would you, no, I'm just asking, like, I'm just curious, how would you do that with that?
By splitting right now we don't have, for healthy people, we don't have the gold standard data set. So I think by splitting the data set, what I have done is by splitting the data set to 70 and 30 ones, and then randomly split the data by choosing some participants, and 70% of participants, and then choosing, and the next choosing 30% of participants manually.
Yeah, so that is what you are splitting the gold standard or reference standard data set into training and testing sets, right? So the answer would be, you can take sample, randomly generate sample out of 500 patients. You can take 100 patients, you can generate you can do the manual review, check it, and then you can run, you can subset, you can take another 100 subset and check whether it is working or not. Does that make sense? Dr. Jones, Dr. Purkasa, please correct me if I'm wrong.
Yeah, no, I think it's a great plan. And I think, Charishma, could you please go back to the slide where you had the time series chart? Because I thought that was very, very interesting. And do you also have a chart that then does like a cluster analysis for this, or no?
No, Professor, I just did this visual only time series charts.
Okay, because that would be interesting to see if you were able to do like a PCA component analysis and show us the components being really separate or not separate. If they are separate, then I think it would work on like the very diverse non-homogeneous group. But if it is not that separate, then I think we would have to find like a different way to do this.
Yes.
Yeah, and one more thing was, so as we go, what you have done is more a personalized. Basically, we are right now moving to personalized medicine, right? Where we are actually recommendations in clinical decision support system. Everything is becoming more towards the patient-centric care. So this one is, we are going more in detail about, okay, which intensity, what kind of workout. So naturally, since every individual is different, as we get very much personalized to an individual, the generalizability reduces down automatically. On the other hand, so I think what should be the future step? Yes, this may have limited generalizability, but if we collect more diverse data, and if we train on the more diverse data set, that would include different race, gender, everything. And then if we train on that, then we may be able to get more like a better generalizability. Right, Dr. Jones, is that correct?
Yes, that's correct.
Thank you.
Yeah, Charishma, this looks like very excellent initial seed work to take this forward. And thank you so much for presenting this to us. I think we are done with all the students in here, and I think the next steps are for us to basically for everyone is to basically submit their reports to their committee, and then the committee gives a grade based on the feedback that you receive. Dr. Jones, is there anything else additional after that?
No, I don't think so. That's all. What first of all, congratulations on all to those who graduate, and those graduating. I have some news. If you want to return back,
thank you, Professor.
If you want to return back to India and become a teacher there, the University of Manipal is asking for graduating students to join their faculty, and they will get a permanent position there. So if you need information, please contact me.
Okay, Professor, sure. Thank you.
Thank you, Dr. Purkayastha, for organizing and for the guests to join us. Congratulations to all.
Thank you.
Thank you, everyone. Take care. Bye-bye.
Bye-bye. Bye.
Thank you, Professor. Have a nice day.